So welcome to our Northwest Research Collaborative meeting. We've got two projects that we're going to hear an update on today. We've got Mads presenting about trauma CTs and incidental findings, and then we've got Ben presenting about his project with cancer in breast implants. So Mads, if I can hand over to you first, if you'd like to start your presentation.
Right, thank you. Now I've been successful before with the share screen, so let's try the success. I have faith that I will be successful again. There we go. Right. I'm just going to do the infamous, can everyone see this share screen? Yeah, okay, we've got nods. I'm good. Right, so my name is Mads. I am one of the core trainees in Preston, and I am here to present what's called the INTRACT study. Basically, it's essentially looking at the incidental findings that are found on trauma CTs. And we're hoping to make this into a regional study with the support from the Northwest Research. Oh, sorry, I think someone's just joined. Right, so that's the plan. So right. So essentially, CT scans, they, especially trauma CT scans, they tend to reveal incidental findings, which can vary anywhere between 30 to 53%. And the type of things that we can find can vary from insignificant findings from just simple cysts on different organs to malignant conditions such as precancerous cells or dysplasia, which results in tumors of different areas of the body and needs formal treatment and management and follow-ups. Based on what's currently out there, we can't really find any substantive pathway or a clear formal understanding on who bears the cost for these follow-up services and the provisions, just the costs and the service provisions for these. So what we wanted to do was try and create essentially a pathway and see what we can kind of produce, what regional pathway that we can produce from all of this. I'm just going to say yes to that. Oh, sorry, I have lost my screen. I have found my screen again. Right, so prior to presenting the study, what we did was a small pilot study. So here in Preston, we are a major trauma center since 2012, and we serves the population of Lancashire and South Cumbria, which is about 1.5 million population. All major trauma centers have their data collected in what's known as a trauma audit and research network data collection point. And what we did was we looked into that data point from May 2019 to June 2020 and reviewed about 1,000 patient notes and looked at all the trauma CTs and had looked through what was found and how it was managed. So from the data that we've collected, 54% of the patients have had trauma CTs, which is essentially a head-to-toe CT scan, and 44% of the patients had a organ-specific CT scan. So that was just purely based on the area of the injury rather than everywhere else. And the remainder of patients we essentially excluded because they either they didn't have any data available, or for some strange reason, they ended up on the TARN database when they actually shouldn't have ended up there. Of these patients, of all these patients, 98% of the patients, approximately 34% were found to have incidental findings, either single incidental findings or multiple incidental findings, along with the other acute pathology related to the trauma that they had faced. So I was just going to put a question out there. Of all the incidental findings, I have just mapped out the findings, the things that we'd found. And can anyone guess what was the most common incidental finding in a trauma CT? I'll give it a few minutes.
I'm going to go for adrenal adenoma.
Actually, good guess.
Lung nodules?
Sorry, what lung nodules?
Non-specific lung nodules of some kind.
That's, again, a really, really good guess. In terms of adrenals, Nick, that was 6% only. Having said that, I was within the limit time frame, and of 1,000 patients, lung nodules was about 8%. The most common thing that comes in at 36% is cysts of the kidneys. And just right behind that is uncomplicated diverticular disease, followed by cysts on the liver, which was the third most common finding. Then we had nodules and often adrenal related pathologies. And one of the most rarest, and I've popped under, was actually a patient who subsequently developed esophageal tumor, stage 3, and that was actually found whilst he had faced his trauma, and then subsequently needed surgery and treatment for that. So in a way, his trauma sort of saved him, I would have thought. But we allocated them into the different spots. Of all of these incidental findings, about 5% of them were followed up. Of the 9% that were required to be followed up. So 9% of the cases had radiologists suggesting that these patients need follow-up, but only 5% unfortunately were followed up or had evidence of how they were followed up. And they were followed up, some within the trauma center where the incident took place and some locally, which was evidenced by clinic letters and other findings, other documents. So our question, who bears the responsibility for this follow-up, and who provides the service provision and the cost that it takes to do these follow-ups for these incidental findings? So the plan is that we engage all the hospitals within the region and input our data into the REDCap. And the information that at the minute we've just thought we would be looking for is any prospective trauma calls over the 3 to 6 month period, the trauma scans that have been completed, documenting them, any incidental findings, any need for follow-ups or mentioned on the report, and the evidence of whether either the parent team or the local hospital carried out these required follow-ups. Why should someone be involved in this project? Essentially, this is very much at the early stages. So you would be leading a project, leading a regional project and developing this project as well, creating a pathway that first of all will be taken regionally, and then if it's obviously successful, maybe we can do more with it. You lead the hospital with what I would call manageable workload, because I'm not sure about other people's on calls, but I don't necessarily get as many trauma calls as despite being in a trauma center as one would imagine. And you'd kind of have an insight into the different types of traumas and the varying degrees of the incidental findings that would come. Oh, sorry, so we've set up a little Gmail address, and we're still, again, like I said, we're coming to the Northwest Research Committee for both trying to get more people, recruit people to get involved in the study, as well as just guidance on how we take the project forward, whether the REDCap information and the type of timelines that we're thinking, and whether that's something that's essentially sustainable. Any questions?
Thanks, Mads. That was fantastic. That's a really impressive bit of background work there. I wasn't expecting you to say you'd been through 1,000 sets of case notes as part of your pilot. And I think some of your questions you mentioned at the end, we can come back to after the other presentation when we have our informal chat, but definitely it sounds like an ideal type of collaborative project, and we can go through with you how we can contact other trainees and the next steps forwards and getting REDCap for it and then the rest of it. Questions wise, just about that project, it's interesting because it's such a change in practice, isn't it, that this would never have been a question when everybody was dealing with their own traumas, and these things would have been dealt with within the local hospitals. But there must be a huge administrative workload in trying to work out how this information gets back to where the patients came from. Was that something that you looked at as well at communication?
Yes, well, where available, we were looked into it, because there were times where, regardless of having evolved and other things, we couldn't see whether there were any further follow-ups present, and where in that 9.6% of the cases where they've asked for follow-up but only 5% had it, it was just based on all the things that were available to us, whether there was any follow-up. So I guess there is some room to say, well, if we were in that hospital, would we have found a piece of document that actually proved that this patient was followed up or not?
And that's something that potentially be really helpful with the multi-sites being involved in this, that you might answer those questions a bit better if those same patients have gone between those two sites, then the team at the other site might be able to fill in some of the gaps.
Exactly.
Yeah, make sure you highlight when you're looking for sites that you're not just looking for trauma centre sites, you're potentially looking for local sites to do some of the follow-up.
Exactly. So it's looking at all the sites, and because we even when I was working in Blackburn, there were trauma calls, and then they end up having their CTs in Blackburn, and then they find something that goes right, it has to go to a trauma center, but the CT remains in Blackburn, and unfortunately only consultants have access to the CTs and etc. So it's almost like it would be so useful to just have that person on that site to be able to lead on that particular patient.
Pretty much any center that would be doing an emergency CT, I guess.
Exactly. Yeah, it's essentially that. Yeah. Right. I shall stop sharing.
Thank you very much.
Successfully. Yep. All right.
And Ben, I think I've made you a co-host as well if we want to go into your presentation.
Great, thanks a lot. I'll just see if I can share my screen. So I'm just going to move things around slightly so I can. Can you see that okay? Yeah, fantastic. Thanks very much for the invite and asking me to speak. I've not spoken in this meeting before. So my name is Ben. I'm a plastic surgery trainee, just finishing up ST7 and then going off to Newcastle for an oncoplastic fellowship in a few weeks' time. We've been running this project and trying to get it off the ground via the Breast Research Collaborative for a little while now, and we're making some reasonable progress. So it's regarding the management of breast cancer in patients in the UK that have already previously had a cosmetic breast augmentation, essentially. So the background to this project is that breast augmentation is increasingly common. It's the most commonly performed surgical cosmetic procedure worldwide. In the States, there are now around 300,000 registered breast augmentations per year. That's gone up by 41% over the past decade. And we expect similar trends to happen in the UK. There were just over 7,000 recorded in the UK in 2019, but that's just on the BARPS registry. So there's probably many more that are happening that are unrecorded. And of course, as the number of patients that have breast augmentation increases and continues to rise, and this cohort ages, there will inevitably be an increase in the number of these patients that go on to receive a diagnosis of breast cancer, or of those patients who are identified as having a high genetic risk of breast cancer and elect to undergo risk-reducing surgery. So what and why is that interesting? I think patients that have had a breast augmentation are different in a number of ways, not only physically, but also psychologically. They may have different aesthetic concerns and expectations. They have less native breast tissue because of the impact of the implant on the gland. And of course, the presence of the implant may have implications for adjuvant treatment, such as radiotherapy. And this poses a number of challenges in their management. And so there are a number, I won't go into these in too much detail, but there are a number of different ways in which they might be managed. One is with breast conserving surgery, i.e. essentially what used to be termed a lumpectomy with radiotherapy following that, but there are issues around achieving adequate margins in the presence of an implant, increased rates of capsular contracture with radiotherapy on top of an implant, and subsequently studies have shown high rates of revisional surgery. There's also issues with mastectomy and reconstruction. So we don't know whether it's best to do this as a single stage or as 2 stages in terms of implant-based reconstruction, or whether patients prefer to have or have at all autologous reconstruction. There are very few reported series of patients having autologous reconstruction. That may well be because patients are used to implants already, and due to the lack of autologous donor sites, patients are likely to be slimmer, and so reconstructive options such as DX flap may not be feasible. And of course, there's also the issue with how you manage the contralateral breast, which may not have a breast cancer, but will have a breast implant. And so symmetrizing against that will be pose additional challenges. So the aims of this project really are to actually establish what current practice is for these patients, and to evaluate their outcomes. And that will inform future prospective studies, which hopefully will include PROMs, cost effectiveness, and also look at the impact of these patients on the breast screening program. So I'll just run you through what we've kind of done so far. So the project, as we started, has got 4 arms, sorry. The first is an analysis and a reporting of the cohort of these patients from the IBRAL-1 study, and I'll go through that briefly in a moment. The second is a national survey of UK practice, which is being carried out by the Newcastle group. And we've been involved as a collaborative and input into that. And then the third arm is really what we're talking about today, which is the regional evaluation of practice, which will be retrospective initially, and then we hope that that will inform a prospective national study with patient-reported outcomes. So in terms of the first arm, which is completed already, really, this was essentially analysing the data from a subset of patients from the IBRA study, which you may or may not be familiar with, but this was a large national collaborative study that looked at the safety outcomes of mastectomy and immediate implant-based breast reconstruction with and without mesh. So we've taken all of the patients in that cohort that had a previous breast augmentation with implants. The problem with taking this cohort is that we can't compare them against patients that had breast conserving surgery and adjuvant radiotherapy, because by definition, all of the patients in IBRA had implant-based reconstruction. So it's just one subset of these patients, but nevertheless, it was interesting. It was the largest and only real UK series reported to date. So we had 49 patients, and we compared them to the overall IBRA cohort, and we found that the patients in the augmented group were younger, as you would expect, had lower BMI, as you would expect, had lower mastectomy weights, smaller tumours, and were less likely to have adjuvant radiotherapy. There was no significant difference in complications between the groups, and it was the first study to report patient-reported outcomes, although we couldn't really draw any significant conclusions from that because we had such small numbers in the PROMS group. It was only around 13. But nevertheless, this has been accepted for publication in Plastic Reconstructive Surgery Journal, and we hope will form kind of a baseline for informing future studies, one of which will be the one that we're discussing today. So that takes us on to the other arms. So as I said, the National Survey of Practice is being performed via a national survey of consultants that are involved in the Association of Breast Surgery, and that's being carried out by the Newcastle Collaborative Group with some input from our collaborative as well, given our previous data analysis in the area. But then what we'd like to go on to do is perform a retrospective regional evaluation of what the current practice is in the Northwest regards these patients. We plan to do that by collecting data regarding our primary outcomes and secondary outcomes, which are listed here. But these are essentially looking at the number of patients who have breast conserving surgery versus the number of patients who have a mastectomy and reconstruction, and comparing both groups to look at how they're managed, their outcomes, complications, length of stay, and whether they required any further surgery. We don't plan to collect patient-reported outcome measures at this stage, just because it's not as effective retrospectively, and it will require significant ethical approval, whereas this could be carried out as a relatively simple quality improvement audit type project that could be registered locally at each trust. The main problem that we have is finding the patients, essentially. So we're lucky enough to have a collaborative consultant radiologist called Megan Bidder, who has identified 23 patients so far over the last 4 years at the Nightingale Centre, which is approximately 5 per year. And that's at the largest unit in the Northwest. But if we can replicate anything like that over a number of sites and extend the data collection over the past 10 years, we would easily have the largest reported series of these patients worldwide. And we could have that on a retrospective basis, which would help us at least to identify how they're managed and the number of these patients that are actually out there to inform a future prospective study. We plan to do that by identifying them from the radiology systems, but in addition to that, local trainees could perform simple searches of MDT performers for search terms. And these cases don't come up frequently. So I think there will be a certain amount of consultant recall that we'd hope to rely on as well, given the small number. And then it'll involve data collection from patient notes, op notes, histology reports, and imaging. And that can all be put into the REDCap database, which we have organised access to, and are currently in the process of formulating the data collection tool. So we've got a steering committee, which is led by members of the Breast Research Collaborative, and some senior consultants who've been involved extensively in research and have been involved in using the REDCap tool, and previously been involved with national collaborative studies as well. I think Rajiv Dave was heavily involved with IBRA too, so he's helping us to develop the REDCap tool for this project. So what we're looking for is trainees in local breast units to help us to identify patients and then collect that patient data. I'm happy to be emailed, or the alternative is to contact the Northwest Breast Research Collaborative or come along to one of our meetings, and we can discuss the projects in more detail there. Happy to take any questions.
Thanks, Ben. Again, that's fantastic, with a huge amount of work already done along your 4 different arms. And it's really interesting, so many of the projects that work well with collaboratives, it's collecting the data that's the problem, where there's the real benefit of having the trainees. You've got this extra level of complexity in having to find the patients. It's almost like a hunt, it sounds like. I'd foolishly assumed there might be some kind of list available somewhere, but clearly that's not the case. So you're really looking for named people at each site to take ownership of helping to build this collection, which clearly it's a problem everywhere. If you said that would easily be the largest number in the world.
Yeah, I mean, I hope that Megan's currently working to look at the CRIS data, which is one of the radiological reporting systems, I believe, across different sites across Greater Manchester. So I'm hopeful that she will be able to identify some of the patients, but the problem is that the images aren't coded in such a way that they're easy to search for breast implants. And similarly, even the screening patients, we can search along the lines of them having additional views, because they all have additional mammograms if they've got implants. But that would leave us with a very, very large number of patients to look through to see if they actually developed a breast cancer. So it's quite—
What about breast care nurses?
Nuanced. Breast care nurses is that's a good idea as well.
Because they might have really, I mean, from when I've done, I mean, it's been a long time since I've done a breast job, if I'm honest, but when I worked at Wigan, they had really, really good lists that they kept themselves that were far surpassed anything that we had at the time. That, I mean, I agree that they may be involved in they may want to be involved in research, and they may be happy to be involved to do the data collection and get their names on a paper. But if they're not, even if they just do if they can identify the patients or point someone in the right direction, that might help.
And it might come back to that individual recall again, that often the specialist nurses are very good at, because even if they've got those lists, it's how do you search through them, and they won't be coded in any kind of way. But yes, the recall.
Yeah. Yeah, we'll explore that. It's a good idea. Thanks.
I'm going to thank you both for presenting those 2, and then stop the recording part of the meeting, and we'll put that on the website, and we'll send an email around just encouraging anyone, if they want to get involved in either of those studies, that they can contact you at the details I've seen up there. We'll get both of your studies and make sure we've got links to the part of the website that you can put all your study information up on. So thank you very much for that, and I'll stop the recording now.